Next up, we've got Elliot Long. Elliot's a paediatric emergency physician and sepsis researcher from the Royal Children's Hospital in Melbourne. And Elliot's well suited to emergency medicine, being excited by both road bikes and mountain bikes.
Thanks, Ben, for the introduction. And thank you for organizing such an amazing conference. It's been such an interesting mix of speakers and presenters. And thank you guys for being here for this presentation. My name's Elliot. I work as an emergency physician at the Royal Children's Hospital in Melbourne, and I have a research role through the Murdoch Children's Research Institute. It's with both those hats on that I have the pleasure of talking to you today about answering the big questions in pediatric sepsis. So to kick things off, just to set the scene a little bit, I'd like to get you to use your mental simulator and send you back to your normal place of work, whether that's pre-hospital, ED, on the wards, or in ICU, in your usual role, and just imagine you're looking after this young boy, Charlie.
How long in hospital? Long bed blocking What's going on?
Don't know if you heard that comment. What's going on? So what do you think is going on with Charlie, and what would you do about it if you were looking after him? And what we thought, I looked after Charlie about 2 weeks ago, what we thought was going on was that he had septic shock, and he had an underlying syndrome and had upper airway obstruction, poor secretion control. We knew fairly early on that he needed securement of his airway. And he also had extreme tachycardia that was persistent despite fluid resuscitation. And he ended up having atrial flutter, and so had multiple competing priorities requiring IV access, IV antibiotics, fluid resuscitation, control of his airway, cardioversion. Multiple teams involved, multiple personnel involved, multiple procedures. And just to give you a bit of a mental picture of what the room looked like managing Charlie, if you were an outsider, this would look fairly chaotic. There are a lot of people, there are a lot of conversations going on, there are a lot of procedures going on, a lot of task fixation. There's a parent in the room who's crying, being looked after by one of our fantastic nurses. And the question I have for you is, in this setting, at this place, in this time, would you be prepared to enroll Charlie in a clinical trial? Welcome to my world. Okay, so enrolling children that are critically unwell in clinical trials is extremely difficult, and for all the reasons you can imagine: diagnostic uncertainty, difficulty getting consent, perhaps even physician acceptability of the interventions that you might be randomizing children to. For all those reasons, the majority of the treatment recommendations we have for critically unwell children, including those with sepsis, are very weak and based largely on expert opinion and observational evidence. So the big three questions that I'd like to talk to you about today are, number one, the big Mount Everest question: what is sepsis? As Paula alluded to earlier on, the definition for sepsis is variable, and as clinicians at the front line, we apply it differently in different children, which leads to difficulties knowing how common sepsis is, what the outcomes for sepsis are, what the cost of sepsis is, and you can imagine trying to get funding for a study on a disease that doesn't have a good definition. This makes it extremely challenging. The second big question, kind of this big sub-peak for sepsis resuscitation is fluid resuscitation. What fluid, how much fluid, when to transition to another form of circulatory support. And the reason this is an important question is that the best evidence we have right now is that our current therapy for sepsis is harmful for patients. And the third big question is triggers and targets. So what trigger do you use to initiate fluid bolus therapy? And what's your therapeutic target? Do you target a blood pressure, a heart rate, improvement in perfusion, just your clinical gestalt? All right, so let's start off with the first question: what is sepsis? So you and I, when we went through medical school and in the early parts of our careers, would have learned that sepsis is infection-related derangements in vital signs called the SIRS, or Systemic Inflammatory Response Criteria. That's essentially fever in the setting of tachycardia or tachypnea. And problematically for children, the majority of febrile children that present to emergency departments meet SIRS criteria for sepsis, so that's more than 90% of kids. And the majority of them don't have sepsis. The majority of them go home with no antibiotics and have no adverse outcome related to that. In the adult world, this was recognized several years ago that the SIRS criteria didn't apply well in diagnosing sepsis. And they've moved to using organ dysfunction criteria to define sepsis, so-called sepsis 3 definition. And so the question for us now is if we can apply organ dysfunction criteria or sepsis 3 criteria to children. And there are some initiatives to change or evolve the definition of pediatric sepsis in parallel to that of adult sepsis. There's an international sepsis, pediatric sepsis definition task force, which has surveyed clinicians to see what people think should be the definition for sepsis in kids. And the majority of clinicians believe sepsis should be infection-related organ dysfunction distal to the primary site of infection. So, for example, if you had appendicitis and you just had abdominal sepsis, or abdominal source of sepsis, that's not truly sepsis. If you had respiratory compromise or CNS compromise or circulatory compromise related to that, that would constitute sepsis. And there's been a really big observational retrospective study done in the United States looking at some different criteria for organ dysfunction in children. What thresholds should we use? What organs should we think of as being sensitive for sepsis in kids, whether it's renal dysfunction or coagulopathy or an elevated troponin. Not a comprehensive list that's been generated. And we're hoping to answer this question to some degree in Australia and New Zealand through a trial called the Sentinel study, right up here. That's an observational study looking at different vital sign derangements and biochemical derangements, hyperlactemia, creatinine, coagulopathy, etc., for prospectively validating organ dysfunction criteria for diagnosing sepsis in kids. So that's currently underway. Some of you may work at hospitals where the Sentinel study is being performed. It's enrolled over 1,800 patients thus far in 9 EDs in Australia, with the plan to include 2 more sites in New Zealand. Okay, second big question in sepsis. This is really close to my heart. This is what I did for my PhD study. Fluid resuscitation, how much fluid, what fluid, when to stop fluid and give alternative therapies. You might think correctly that we've already answered this question. So this is the result of the FEAST study performed in sub-Saharan Africa, published in 2011, which showed surprisingly that children that received fluid bolus therapy had worse or higher mortality than children who received no fluid bolus therapy. So this really pulled the rug out from under our feet in terms of one of the cornerstones of therapy for pediatric sepsis. How could what we do every day in our clinical practice potentially be harmful for children? And we can talk a little bit more about this during the question period if there's interest. But again, question I have for you, if you were to try and apply these data in your clinical practice, would you be prepared to give no fluid bolus to a child with sepsis? For the majority of us, that'd be a very challenging thing to do and not represent what our current practice is and not represent what our guidelines suggest we do at the moment. There have been attempts to answer this question in the Western setting. This is the fluids in shock study that was performed as a pilot in the United Kingdom, trying to restrict the total volume of fluid bolus administration in children by comparing 10 to 20 mils per kilo per bolus in kids with sepsis. And the FISH study was deemed not feasible after the pilot was performed because poor outcomes, mortality, was so uncommon in their patient group that the sample size that would be required was too big to feasibly complete the study. So there's a big problem the paradoxical problem in Western countries where we want to study things we think have severe outcomes, but the outcomes are not as bad in the Western setting as they are in resource-poor countries. So perhaps we need to rethink trial design, and maybe the traditional randomized control trial isn't the way to go for answering big questions in sepsis. When you think about traditional trials, they're like a train on a train track. You know, the patient population you want to enroll, it's not changed during the study. You know, the intervention you want to use, it doesn't get changed during the study. You know, the sample size, you don't change that during the study. You know the outcomes, and they don't change during the study. You never actually find out what the results of the study are, and if all the assumptions you've made along the way are correct until the study's over, and you analyze the data, and you find out if the assumptions that you made related to sample size and population were correct in the first place. And for that reason, because of the multiple assumptions that you have to make, many of which will turn out to be incorrect, it's common for randomized controlled trials to not answer the question that they set out to answer in the first place. So there's another type of trial design called an adaptive trial. And the way to think about this design or trial design is it's more like a hike with a map and a compass. You have some idea where you want to go. You don't really know how you're going to get there, and the route you take may change depending on the conditions you encounter along the way. The benefit of performing trials in an adaptive way is that you can change in a planned way the trial design, the interventions, the sample size, based on results that come in as you do interim analyses along the way. And over time, you'll allocate more participants to beneficial arms of the study and fewer to less beneficial arms of the study. So you're incorporating existing high-quality evidence into ongoing care for children that are enrolled in the study. Over time, you might drop some arms and add some arms depending on the results. And in terms of recruitment numbers and sample size, this is called kind of the Goldilocks or just right principle. Because you're doing a whole bunch of interim analyses, you're at low risk of under-recruiting, because the only reason you'll stop the trial early is because of futility. And you're likely to stop the trial once statistical significance is met, so you're unlikely to over-recruit patients to the trial as well. And the other benefit of adaptive trials is you can look at subgroups. So that's important in sepsis for all the reasons that Paula mentioned. There are many phenotypes of sepsis based on age, infective organism, etc. So what would this look like in practice if we wanted to design an adaptive trial looking at, for example, fluid volumes? I think most of us are pretty comfortable giving 40 mils per kilo, middle of the range kind of fluid bolus volume, total fluid bolus volume before starting an inotrope. You could alter that a little bit on either side, and then look at what happened over time. Perform a planned interim analysis. Depending on the results of that, you might hypothetically find that children who received more fluid had a poorer outcome. Children who received less fluid had a better outcome. So the study would be designed in such a way that you'd have a planned action based on those interim analyses. And the planned action would be to reduce the allocations to treatment arms that were associated with poor outcomes and allocate more patients to treatment arms that had better outcomes. So just by being involved in the trial, you're actually allocating preferentially patients to the arms that are beneficial. You can see how over time, with multiple iterations of this interim analysis, that you just start to approach the truth. And you may drop one study arm eventually, and you may add another study arm if you found that lower volumes seem to be associated with a beneficial effect. So this might help over time to get over our hesitancy as clinicians to give limited fluid administration in children with sepsis because it's not part of our standard current practice. So the holy grail over time would be to get to this stage. We'd find the truth. The other thing, there are some important subgroups that we need to pre-specify in performing a trial like this. Some of the criticisms of the FEAST study were that they included patients who had primary meningitis. So, of course, if you administer fluid to them, they'll get cerebral edema and may die. Same with lungs, primary respiratory infection. Of course, they'll get pulmonary edema, and that may contribute to their morbidity and mortality. And also subgroups related to resource availability. So if you had performing this trial in an under-resourced environment, you could compare that to performing the performance of subgroups in more well-resourced environments to see if the setting that the fluid is administered in has some bearing on outcome. Okay, next big question is what fluid to give in sepsis. So the question of crystalloids versus colloids has largely been answered by the SAFE study almost 2 decades ago. That was a blinded study, so clinicians were blinded to the fluid that they're administering in intensive care units to critically unwell adults. In theory, colloids should have a volume-sparing effect and should be administered at a volume of about 1 to 3 compared to crystalloids. And in practice, this SAFE study found that the volumes that were actually administered in practice were almost identical. That's probably because the lining of the blood vessels, the vascular endothelium in the setting of sepsis, is permeable and leaks no matter what fluid you're administering. So the question for us now is really which crystalloid to use, 0.9% saline or balanced fluids. And balanced fluids comprise Ringer's lactate, Hartmann's solution, and plasmolite. And the concern is that 0.9% saline has a supraphysiological chloride concentration. So it has a chloride concentration of about 154 millimoles per liter of chloride, whereas you and I in our bloodstream have a chloride concentration of about 100 millimoles per liter. And that excess chloride, you guys will see this in clinical practice, if you administer large volumes of saline, the chloride will go up and the pH will go down due to what's called the hyperchloremic metabolic acidosis. And that's thought to be harmful for patients' kidneys particularly. Multiple adult trials looking at balanced fluids versus saline, none of them showing any important difference between the two fluids until earlier this year, large meta-analysis. So this is mega numbers, greater than 35,000 patients together in this meta-analysis showed that there was a 9% reduction to 1% increase in mortality using balanced fluids compared to 0.9% saline. But all these studies were performed in adults. They were all performed in ICUs where the majority of fluid resuscitation had already taken place, and they included all comers. So they included post-op surgical patients. They included not just patients with sepsis. And the biggest treatment effect seems to be in children in patients with sepsis. For that reason, we're currently undertaking this study called the Prompt Bolus study, comparing balanced fluids to 0.9% saline in children with sepsis. This is an international pragmatic RCT in 3 different research networks in Canada, the US, and Australia and New Zealand. And the primary outcome for this study is a renal composite outcome called MAKE30, major adverse kidney events within 30 days of randomization or hospital discharge. And the really exciting thing about this is that it's a collaboration between research networks. So we're hoping to enroll more than 8,000 patients in this study. And to do that, you really need collaboration between research networks. And that's probably the way of the future for us with performing big trials in sick kids. I'd just like to touch on some alternatives to fluid administration. We kind of think that fluids and inotropes are the only 2 things that might help with the circulatory support in children with sepsis. This is a study performed in Thailand in adults with sepsis, where they administered blinded to clinicians low dose of peripheral noradrenaline, so 0.05 micrograms per kilo per minute of noradrenaline, before starting any fluid administration. They showed that there was a statistically significant improvement in resolution of shock and a non-statistically significant improvement in mortality in the patients who were administered early low-dose noradrenaline. So perhaps a therapy for us to keep in mind for the future. And the other thing is early steroids. So this is the results of the adrenal trial showing in adults, again, showing no difference in mortality between adults who got steroids or no steroid, but an improvement in shock resolution. And perhaps this was an ICU-based study, and perhaps the horse is already bolted by the time patients get to ICU. They've already had their fluid resuscitation. All the harms associated with excess fluid administration has already taken place. So perhaps administering steroids early would be beneficial in children with sepsis. Okay, triggers and targets, last topic here. What do you use in your clinical practice as a trigger for administering fluid boluses in children with sepsis? For most of us, myself included, it's clinical gestalt. It's what the patient looks like, their conscious state, their perfusion, their heart rate, and blood pressure are in some ways secondary. The other side of this coin is, when do you know if you've given enough of that therapy? When do you stop? And again, there's, I think, a large amount of variability in what we do in clinical practice as a trigger and target for therapies in sepsis. So if we were to design an adaptive trial looking at different blood pressures, targets for sepsis, it might look something like this. So we have a target age range, children that are 1 to 2 years of age. We have some pretty standard blood pressures. This is probably what would be recommended in guidelines for a target blood pressure, and we can look a little bit on either side and do our interim analysis, planned outcomes. In this case, we find that the best outcomes are associated with this middle blood pressure, and therefore we allocate fewer children to the other arms and more children to that 55 millimeters of mercury arm. And again, over time, we might find that this blood pressure is associated with the best outcomes. We drop all the other arms, and every patient from then on gets allocated to that target blood pressure. We've reached the truth. Okay, so that's called an adaptive trial. How do we put all these things together? So we've looked at a number of different ways to study different therapies in sepsis, and the vision really is that any child who presents to hospital and is diagnosed with sepsis gets enrolled in a clinical trial. For some kids, this may just be observational. If they don't meet inclusion criteria for any other trial, they might just be observed to monitor their outcomes. For some children, it may be to look at fluids and inotropes, randomize them to lower or higher dose fluid or earlier or delayed administration of inotropes. We can include kind of strata of triggers and targets for blood pressure and heart rate in there. Another treatment arm or domain might be administration of early steroids. And then we should leave some room for future therapies that we don't know about yet. So this concept is called an adaptive platform trial, multiple different interventions that may interact with one another, but we can tease out those interactions under the umbrella of this platform trial. So in summary, the big questions in pediatric sepsis may be able to be answered using these two concepts of collaboration between research networks, giving us the power to answer the big questions, and secondly, novel trial design, such as the use of adaptive trials to modify our therapies over time. And I hope we can use these strategies to improve the evidence for care of children like Charlie at the most vulnerable time of their hospitalization. Thank you very much. For you.
That's great. Thank you very much, Elliot. Does anybody have any questions for Elliot? No questions from the audience?
Hi, Elliot. I was just wondering if you could talk a little bit more about FEAST and the evidence, and are we using this in sepsis management at the moment in pediatrics? Or?
Thanks, Mandy. Was the question about the FEAST study?
Yeah, the FEAST study.
And why we're not using that evidence?
Yeah.
Currently? Okay. I think that I'm interested in others' opinions on this. I think that a lot of the criticisms that have been raised at the FEAST study are probably not valid, and that we should. And so those criticisms are things like the study setting, lack of availability of resources to manage organ dysfunction that might result from fluid administration, the inclusion of patients with severe malarial anemia, so administering fluid to them worsens their anemia, therefore makes them at more risk of harm from fluid administration. Children that have primary infections in the lungs or the CNS that might be at risk of edema in those systems if we give too much fluid. But the FEAST study was performed in such a way that they could take all those patients out of the mix and look at what you and I think of as being just bacterial sepsis, meeting the definition that we use in our clinical practice. And they found that in that and every other subgroup, there was no treatment benefit from giving fluid administration. And the second, so no benefit in any subgroup or overall in the study is one major take-home point. And the second one is that there was a dose effect. So the study protocol was changed partway through the study being performed because the study team didn't think it would show enough beneficial effect. They designed the study to show that fluids were beneficial to children that had sepsis, and they thought, 20 mils per kilo is not enough fluid to give. So they changed the study protocol to administer 40 mils per kilo, and they found that the patient group that got more fluid did worse. So there's no subgroup that benefited from fluid, and there was a dose effect. So both those things give me major pause for thought giving fluid to children with sepsis. And I think it's changed our practice in a creeping way. If we were to give this talk 10 years ago, our mindset would be you can't give enough fluid to kids with sepsis. You can flood kids with sepsis and that doesn't do any harm. And our guidelines reflected that, up to 200 mils per kilo of fluid. Nowadays, we're mostly giving smaller volumes of fluid. So the aliquots of fluid we're giving are smaller, and the total volume of fluid we're giving is smaller. So I think we're kind of slowly creeping towards incorporating that evidence into our day-to-day practice. But again, it'd be really challenging to not give fluid boluses in kids that you suspected of having sepsis at the moment.
Great answer. And Paula, I'm seeing a nod. Is that agree? Yeah.
Yeah, totally.
Wonderful, cool. Thank you very much, Elliot. That's awesome.